Welcome. I'm Dr. Ira Chasnoff. I'm going to be talking with you today about marijuana use and pregnancy, looking at it especially from the prevention perspective. What I want to share with you is, first of all, the relative changes that have occurred in the use of marijuana over the last 50 years, the impact of marijuana use during pregnancy on pregnancy outcomes, and explain the impact of prenatal marijuana exposure on infant and child outcomes. And finally, we want to talk about how we take this information and educate the public, professionals, and state legislatures on the importance of sending out the message, no amount of marijuana is safe to use during pregnancy. So the first question is, what's really changed over the last 50 years? Well, the fact is that marijuana today is much stronger, with THC concentration steadily increasing over each decade. For instance, in 1985, the average concentration of THC in marijuana cigarettes was about 3%. By 1993, it had gone up to almost 4%. And by 2008, it was 9%. Today, across the country, especially in states that have legalized recreational marijuana use, you can find marijuana cigarettes that have as much as 15, 30, 40% THC. The other significant factor that has emerged is that the majority of the public states that marijuana should be legal. And that rate of proponents for the legalization of recreational marijuana use continues to increase every year. And finally, and probably most importantly for us as clinicians, is that public attitudes toward marijuana have changed so that it's seen as a totally harmless drug. As I said, rates of marijuana use have changed dramatically over the last several years, and we have seen that change in rates of use in pregnancy also. The 4Ps Plus, the universal screening instrument that we use to identify women at risk for substance use, across several states showed that from 2008 through 2012, the average rate of marijuana use in pregnancy was about 9%. Our most current data from 2013 through 2022, rates vary from 15 to 25% on average. But in many states, the rates are much higher. So this tells us over time that legalization of marijuana does seem to have an impact on the rate of use during pregnancy. In Colorado, recreational marijuana use was legalized in 2012 and became effective in January 2014. One group studied delta-9 THC in meconium samples in newborns at 2 time points. The first was the first 9 months of 2012. Once the legalization of marijuana legislation had been passed, and then again in the first 9 months after the legislation became effective in 2014. So we have 2 time periods, the first 9 months of 2012 and the first 9 months of 2014. And this group studied meconium samples in newborns in Colorado versus multiple other states that had not legalized marijuana use. Now, a newborn's meconium will reflect any drugs, any substances the pregnant woman took during the 3rd trimester of pregnancy. Interestingly, the rate of positive meconiums did not go up significantly in either Colorado or in the comparison states where marijuana had not been legalized. However, the concentration of THC in the meconium, although it stayed the same with no increase in the non-legalized states, in Colorado, the concentration of THC in the meconium almost doubled from 2012 to 2014. So what this tells us is that the initial response to the legalization of recreational marijuana use in Colorado was that more pregnant women didn't start using marijuana. However, those that were using marijuana were using more. So this was just a very initial look at the impact of the legalization of recreational marijuana use on rates and patterns of use during pregnancy. So that's where we are. And the greatest problem we face from the perspective of prevention is the public belief that marijuana use is harmless, even during pregnancy. What we'll talk about is the impact of marijuana on pregnancy outcomes. In our previous session, we talked about the prevalence of marijuana use during pregnancy and showed how rates are steadily increasing. What we want to do in this session is talk about marijuana's use on pregnancy outcome. Now, why is this so controversial? Why are studies of marijuana use so difficult to interpret? Well, there are several reasons. First of all, most studies have very small or highly selected samples. There's a lack of any prospectively collected measures of cannabis use early in pregnancy. Although appropriate control through statistical analysis can be utilized to help us understand the power of these confounding variables, it's still very difficult. The other issue is that many women during pregnancy are polydrug users if they are using substances. And so we have the confounders of other substances, especially tobacco and alcohol. And finally, when we look at studies across the board, there are differences in the study designs, and so you get conflicting information. So what I'm going to try to do is bring all these studies together and give you some idea of the consensus as to the impact of marijuana on pregnancy outcome. One of the largest studies, done in 2012, examined 24,874 live births. Now, what the researchers did is they assessed substance use patterns at the first prenatal visit. The mean age of the women was 28.4 years, and marijuana use rates were divided into three categories. 26% of the women had ever used marijuana in their life. 9.5% were using marijuana prior to pregnancy, and 2.6% were continuing to use marijuana even though they knew they were pregnant. Now, the researchers were able to control for a variety of factors. First, socioeconomic and demographic characteristics were collected on all women. Patterns of tobacco use, alcohol use, and use of other substances besides marijuana, alcohol, and tobacco were collected. What these researchers found, when controlling for all other factors, was that women who used marijuana during the pregnancy had babies who were significantly smaller at birth. They had lower birth weights, they were shorter in length, and there was a higher rate of prematurity with a lower average gestational age. The babies also, if their mothers used marijuana through the pregnancy, the babies also were more likely to be small for gestation age and to need to be admitted to the neonatal ICU. There have been multiple other studies done, more and more every day. One of the most disturbing was a large epidemiologic study that was done in 2008, when researchers found that if a woman used marijuana in the first month after conception, there was an increased rate of the babies being born with anencephaly, that is, missing the front part of their brain. Now, embryologically, that makes sense. What we know is one of the first steps in embryonic development is the development of the central nervous system, the brain, the spinal cord, and it develops from something called the neural tube. Now, the neural tube is literally a tube that begins developing soon after conception, and as the embryo grows, the neural tube closes, and that neural tube becomes the whole basis for the central nervous system. The neural tube closes between 16 and 22 days after conception. It appears if a woman is using marijuana during that period of 16 to 22 days after conception, there is a possibility, increased possibility, of the baby being born with anencephaly. Prevention, prevention, prevention. Most women don't know they're pregnant at 16 to 22 days. So if a woman says, I'm using marijuana, but as soon as I find out I'm pregnant, I'll stop using, that might be a little too late. We have to get the word out. Several studies have confirmed the previous study I told you about, in that there is decreased fetal growth with higher rates of low birth weight babies. And we know the implications of a baby being born low birth weight. The baby is much more likely to have developmental delays and long-term difficulties. Now, there have been a couple of studies that have shown no impact on growth, but the great majority of studies, especially the more recent ones, have shown an impact on growth, and animal studies are confirming decreased fetal growth with marijuana use. Another study in 2014 found in a large survey of pregnancies across the United States, that if a woman used marijuana during pregnancy, there was a 2.3 times increased rate of stillbirth. The United States has one of the highest stillbirth rates among developed nations in the world. What impact is the legalization of marijuana and its increasing use during pregnancy going to have on our stillbirth rates? We don't know, but we need to get that information out to the public. So what do we know? We know there is a public attitude that marijuana use is safe, especially during pregnancy. However, we have to get the word out that what the research is showing, even the newest, well-controlled, well-designed studies, what these studies are showing is that babies who are born to women who use marijuana are at increased risk for being born stillborn, are at increased risk for being low birth weight, for being premature, and placing them on a pathway for poor developmental outcome. That's the importance of prevention and getting this information out to the public. In the previous two sessions, we talked about the increasing rates of marijuana use during pregnancy and the impact of marijuana use on pregnancy outcome. In this session, we're going to look at newborn and child outcome over the long term. Why is this a concern? Because marijuana is lipid soluble, which means it gets absorbed into fat very readily, and it's of low molecular weight. So basically, it's a small particle. Those two characteristics help marijuana cross the placenta very readily and, importantly, cross the blood-brain barrier so that marijuana will cross into the fetal brain. And in autopsies of stillborn infants whose mothers used marijuana, you find high concentrations of THC in the fetal brain. Now, we talked about the importance of understanding 16 to 22 days after conception being the period of neural tube closure. But in addition, the endocannabinoid system is developing. Now, the endocannabinoid system is the naturally occurring cannabinoid system in everybody's brain, but it's much higher density in a fetal brain than it is in an adult brain. And what we have to understand is that this early development in the first weeks after conception, this is building the basic scaffolding for brain structures across the board. The cerebral cortex, the amygdala, the hippocampus, the cerebellum, the basal ganglia, all of these organs that we know exist within the brain are all developing very early in pregnancy. Now, the question is, what impact will marijuana actually have on the infant outcome from the perspective of brain development? The most obvious that's been found is changes in newborn neural behavior. Now, what is neural behavior? Neural behavior is we as humans interact with and respond to the world around us. It's how we take sensory information in and respond to it, use it to guide our behaviors, our emotions, our responses. These processes are affected in the newborn who was exposed to marijuana through gestation. There are multiple studies by multiple different researchers that show that babies born with prenatal marijuana exposure are much more irritable and have more tremors than babies that are not exposed. They have difficulty habituating to loud noises, to disturbing lights, to any of the activities around them. Under normal circumstances, we as humans are able to block out negative stimuli. We can recognize what's important and what's not important to attend to. This ability, called habituation, is decreased in babies whose mothers use marijuana. These infants also have difficulty regulating their state of arousal. If you've ever seen a newborn infant lying quietly in his crib begin to awaken, become more alert, responsive, and in fact may even move to crying, most newborns have self-regulatory behaviors. They can self-soothe. So if you watch this newborn, if he does reach irritability and crying, he'll bring his hands to the midline, he'll rock his head, and you'll see that they have self-soothing behaviors. That's called state regulation. Infants whose mothers have used marijuana during pregnancy have difficulty with state regulation, are not able to self-soothe. Now, all of this, of course, leads to difficulties with sleep. And so we see frequent sleep disturbances in infants whose mothers have used marijuana. Studies have looked at orientation, the ability of the infant to orient toward various stimuli, especially auditory stimuli, visual stimuli. So a newborn infant, through a month of age, should, if he hears a sound, should be able to turn his eyes or his head toward that sound, wherever it may be coming from. He should be able to attend to visual stimuli. And so if you put your face in front of the newborn, he will focus on you, and you can even see him, he will track a little bit. These types of behaviors are significantly reduced in infants whose mothers have used marijuana during pregnancy. Granted, there is one well-known study, well-publicized, that showed that babies whose mothers used marijuana did just fine. They had normal birth weights, and their neural behavior and in fact their development were actually better than non-exposed infants. But if you look at that study carefully, what you'll see, it was a very small population of women in Jamaica. They were high socioeconomic class women, and they did not smoke marijuana. The babies that were exposed through marijuana teas. And we know that THC is much less likely to be absorbed through the GI tract to get into the mother's system than it is if she's smoking. So that particular study done in 1994 really doesn't have any implications for what we see here in the United States. There have in fact been studies looking at the long-term outcome of children prenatally exposed to marijuana. The first step is looking at animal studies, which have shown that when you give marijuana to the pregnant mother, her offspring have increased rates of memory deficits and hyperactivity. Now, looking at human studies, there are several studies that show long-term children with prenatal marijuana exposure have impaired neurocognitive skills, especially deficits in behavioral functioning. One large study out of Canada showed that children at 14 years of age who had been exposed to marijuana prenatally, when you control for all other factors, those children had significantly increased rates of difficulties with executive functioning, the ability to plan and complete a task, the ability to sequence, to understand the consequences of behaviors. In a study out of Pennsylvania, it was shown that when you control for all other factors, a teenager who was exposed to marijuana prenatally is much more likely to use marijuana himself or herself. And in one study, a group of 18 to 22-year-olds underwent functional MRIs. So they did real-time MRIs, and these young people were given tasks. And what was shown among the 18 to 22-year-olds who had been prenatally exposed to marijuana, had never used marijuana themselves, control for all other factors, on functional MRI, it was shown that there was altered neural functioning, especially effects on short-term memory. So what this tells us is that marijuana, in fact, is not a harmless drug. It crosses the placenta and accumulates in the fetal brain. It interferes with neuronal cell development in the fetal central nervous system. And animal studies document many of the same effects as human studies. Low birth weight, stillbirth, prematurity. These are all issues that the public must be educated on. So what makes prevention so difficult? First of all, there are a lot of opinions, informed and uninformed, on both sides of the issue. The politics of marijuana intercede with thoughtful discussions. States rushing to find money are legalizing recreational marijuana use without educating the public. The science is new, and many of the studies that we are seeing now contradict many of the earlier well-publicized studies that said there was no effect of marijuana on pregnancy outcome. And in fact, what has happened is public law has moved ahead of public health as the driving force for change. So where does that leave us as clinicians? In day-to-day practice, we have to consider marijuana in the context of alcohol and tobacco use, especially when we talk about pregnancy. We have to give a consistent message that no amount of alcohol, no amount of tobacco, no amount of marijuana is safe to use during pregnancy. And if someone is planning a pregnancy, considering getting pregnant, or having sex without birth control, they should be advised to stop using marijuana. If you are prescribing medical marijuana, you should educate the woman about the impact of marijuana on pregnancy and the child. Ask about the possibility that the woman might be currently pregnant, and offer pregnancy testing to all women of childbearing age prior to giving a prescription for marijuana. And we must not forget the men. When we are educating women about reproductive issues and marijuana, we must also be talking to their partners and letting teenage boys know that no amount of marijuana use is safe to use at any time during pregnancy. This is the message we have to get out. There is good evidence now that marijuana use by men has epigenetic implications and can change the structure and function of the sperm that they contribute to the conception. From a public health perspective, medical marijuana legislation should include public, professional, and legislative education about the impact of marijuana on pregnancy and child outcome. Informational materials should be available at all sites that prescribe or sell marijuana. And why don't we consider government warning labels, similar to the labels that are put on bottles of alcohol? These are some simple steps we can take to ensure better pregnancy outcomes for all of our population. Clearly, we need more studies, well-controlled, well-designed studies, to really understand the impact of marijuana use on pregnancy. And then we need to get information out to the public and let them know, I'll say it one more time, no amount of marijuana is safe to use during pregnancy. Thank you for joining me today in this class on marijuana use in pregnancy. I hope you can take this information and use it in your clinical practice and as you develop public health policies.